Okay, so I'm going to tell you about the SONATA project and what we've done in terms of looking at early diagnostics in ovarian cancer. And then we're going to kind of recap on recognising symptoms. I know I'm talking to people who already know this, but it's just to re-emphasise that. A lot around the diagnostics and the pitfalls, and then really kind of homing in on how to get the most out of your GP. So let me start off with my involvement with ovarian cancer research, which concluded just a few months ago. I had the privilege of working alongside Professor Vanguard, who I believe is speaking with you later on. She's completely kick-ass. I love her. She's the only lady that wears a sari and then uses the F word during a meeting. How cool is that? So do let her know that I told her that as well. She's a hero. But I worked alongside her, and we have 14 practices in and around Birmingham. I'm part of a large group of GPs, we're called Modality, so we accessed 14 of our practices. And what we did is we looked at the diagnostics that have been done at GP level. So we looked at the blood test, the tumour marker, CA125, and we looked at ultrasound. Starting off with CA125, and I'll come on to it in a little bit, what we did is we piggybacked. When somebody ticked a CA125, we added another tumour marker, which was called HE4. So people had 2 tumour markers in this research project. And so there's research in hospital that showed that that second tumour marker had increased the uptake or detection of ovarian cancer at early stages. So we wanted to know whether that would work out in the community. So doctors didn't have to, or nurses didn't have to think about it. They ticked a CA125 as they normally would do, and the lab automated the second test. So that's called HE4. And what happened was there was thresholds, like there is with CA125, what's normal, what's abnormal, and the whole thing was called ROMA. So we gave them a score back and then told them what to do. So it was fairly straightforward. It was either high and they referred on, or low and they did what they normally did. The second bit of it is we looked at ultrasound scans. As you know, sometimes before referral, people will get both blood tests and scans. There's variation in that, but we looked at the quality of scans that were done in hospital. Okay, and what Sudha did is she trained up her team to make sure that they were using the same standardised way of reporting for ovarian cysts, and that was called IOTA Adnex. So upskilled her team and then looked at the impact of that. And then Ovacome helped us with the engagement to try and say, well, that's all well and good doing an extra blood test and looking at the quality of scans, but what about the women that aren't aware of symptoms? What about the women that aren't coming forward? So they helped us with a community engagement plan or project, and they reached 100,000 women. And I hope some of you were aware of this when it was going on. So we partnered with Ovacome throughout, and actually we did a series. There'll be a video probably somewhere of me on a website with my colleagues talking about the BEAT awareness campaign in different languages, because I come from, I've been 35 years in Birmingham. I work in a very deprived area, Aston and Handsworth, where English is not people's first language and literacy is a real problem. So, we wanted to address that. Hopefully that fills you in, and I'm gonna tell you a little bit more, but I am here for you today. So if I'm going off piece and you're thinking this is not relevant to me and my family, then please just stick up your hand and I'm happy to answer questions. Who is not aware of BEAT? I'm not going to over-label it, but does anyone feel comfortable putting that? You're all aware of BEAT. And actually it was the very first time that I'd come across this, and it's just so straightforward, but what we need to do is continue to get this message out, okay? And that's not just with our communities, we also re-emphasise this within our primary care team. Why is this important? Well, again, I know that I'm speaking to people that have already gone through this with either yourself or with your families, but there's a 1 in 52 lifetime risk of ovarian cancer, with about 7,000 cancer diagnosed. But we do know that a lot of that is at the late stages, and we do know that when it's diagnosed late, the survival rate drops off. We also know, and I'll provide some outcomes from the research, that unfortunately women from Black and Asian communities are the ones that are often being diagnosed quite late as well. So that awareness piece is particularly in those communities, but actually throughout. this is the bits that I wanted to share to you about the research outcomes. And again, a lot of you may be aware of that, but it's emphasising this and getting the message out. And actually, it's been an education for me to know that, 50% of CA125 will miss ovarian cancer at early stages, okay? That's a significant issue. A blood test that everybody kind of ticks and expects will miss half of ovarian cancers. And the other pitfall of it is it can go up with so many other benign conditions, non-ovarian cancer conditions. I have only just had, interestingly, an email while I was away with a lady who somebody ticked a CA125 in a 30-year-old and it was elevated and she's been put unnecessarily on a 2-week referral pathway and has rightly complained to the service to say it's caused a huge amount of anxiety because she has endometriosis. And now she's on a cancer referral pathway. So it works both ways in the sense that we miss cancers, but also we're putting women unnecessarily onto cancer referral pathways and flooding the 2-week referral pathways. And that's really relevant because we're hearing all about the NHS, the limited resources and how the workforce is really strained, and we can't be flooding these really crucial appointments with the wrong people, okay? And so that's why it's important that we know about CA125, we know when to use it, and we also know that it's not going to be able to pick up all ovarian cancer. Just because I want to gauge whether I'm actually sort of talking to you guys about stuff that you already know, how many people are already aware of this? So, okay, so half of you are already aware of it, okay? Okay, so that's something that I'd just like you to take away. And the reason I'd like you to take away a lot of this is because we know with the best will in the world that you have to advocate for yourself, okay? And I'll come on to that in a bit. And information and knowledge empowers you to advocate for yourself, and I'm all about that, okay? I would love to say to you that all of your GPs and nurses will know this already, but the fact is they probably don't, and therefore, if you know somebody going down a route like this and that comes back normal, then the next thing you need to kind of do is go, well, hang on, were you aware that it misses ovarian cancer in half cases? So what else are you going to do to help me figure out what's going on? And that's how I would expect to be spoken to, okay? Maybe not in that rude way, but like, do your job, no. Okay, so those were the little bits of Roma that I told you about. What we did was we had 35,000 samples, so it's quite a significant sample set, okay, that went off to the lab and looked at whether it made any difference. Now, here's a bit of sad news, and I remember when Sudha dropped this on a call, she said, it hasn't made any difference, okay? Adding that extra blood test, well, it wasn't an extra tumour marker, made no difference. And we really expected that it would because it had made a big difference in secondary care in hospitals, but it did nothing in primary care. And I remember at that point she was quite sad because it had been quite a significant uplift. It was about 20% extra cancers were picked up when they got through to hospital, but it hadn't shifted the bar at all. So we were a little bit disappointed. But there's always a silver lining, right? So what we've realised is the tumour marker didn't make any difference. The blood test is what it is. But the ultrasound was the biggest thing. And that's what we're now going to focus on our next project. I don't know whether I'm skipping slides, but I'll tell you about that now. Oh yeah, well good, okay, so I am following my thoughts. The ultrasound was the biggest thing because when she standardised the reporting of ultrasounds in hospital, she found, and this is a massive thing, that there was 20% less unnecessary surgery. Okay, that was huge. Huge for the woman, okay? And what I mean by that is suspected ovarian cancer, with the best will in the world, with all of these diagnostic pitfalls, some women go on to have surgery to figure out what's going on. And because they actually had a decent ultrasound report, they found that 20% less women needed that surgery, unnecessary surgery, okay? So there's obviously a benefit for that woman going through that, because the last thing you want to do is go through an operation and find out that actually you didn't need to go through it in the first instance, or even worse still, that you have a complication, okay? So we've actually made things worse for you. The other thing is from a system point of view, in terms of the fact that, you know, the cost as well as everything else. So this is where we'll get a lot of attention and traction, okay? And what we're hoping to do as the next spin-off, and maybe she'll talk to you about this later on this afternoon, so sorry if it's a bit repetitive, is to bring that model of care into the community as a next research project, and really make sure that the quality of scans that are being done via your GP before you even go on to hospital is actually of a much better standard. Okay, so that's the next hope and plan. I guess the big, and the other reason that we need to do this is because, and I don't know what your journeys are, but often you'll find that there's loads of repeats of tests. Okay, once you got referred, they were doing blood tests again and scans again, because actually, because of this quality assurance, they wanted to make sure that part of it was to monitor it, but also because of the quality concerns that there are in community scans. So this is where we need to improve. What does this all mean for you? Well, I think the main thing is, if you're helping and support other people through their journeys, just remember what I've said about CA125 if you were not aware, and remember about the concerns regarding ultrasound quality. And it's never great to sort of tell people that the scans may not be the best, but it's really important that you know. And the reason for that is that if you've still got symptoms and you're not getting answers, then I think you need to be able to find somebody that can give you those investigations and those answers. And that might mean that despite the fact that it's normal, and this is the big message, your CA125 may be normal, your ultrasound may be normal, but if you have persistent symptoms, you need to be referred on for further investigations. And I recall a woman who I was monitoring in gynaecology clinic, who we did exactly this. We followed national guidelines. She had an ovarian cyst. She was after menopause. We did everything that we needed to do, monitor her every 4 months. But the one thing that she said is, I'm still in a lot of pain. I'm in a lot of pain and I'm waking up at night. And I thought, this is not right. And nothing had really changed with doing everything that we were meant to do. So we went for an MRI scan, and that's when we picked up ovarian cancer, and she was handed over. I spoke to my consultant afterwards to say, should I have done the MRI earlier? She was like, no, you followed everything that you did. What happened was that lady was transforming into cancer while you were monitoring her. And thankfully, probably what you have done is picked it up at an earlier stage, okay? So if these diagnostics aren't giving you the answer, there are other diagnostics that can be done, and there are other specialists that need to be involved in your care. I hope that makes sense. Have I lost you so far? Are you okay? We're good. You know all of this. Right, okay. This is the bit, right, that I should stand here, and you can't heckle me because I'm trying to be one of the good guys that are making some change. I know how hard it is to get a GP appointment. I get this, okay? I really do. So it's really easy for me to say, get an appointment as soon as possible. In the real world, that's really hard. And a lot of them have got online forms now. I like my online form with my GP, some people don't, but I understand that it's hard to get an appointment. But I'll give you a few tips of how we can get around this. I think the key thing, and I'm going to stand back so I can actually make sure I say this properly because this is really important, is if you're getting dismissed from your symptoms, and we know that through the research that we've done, it takes at least 3 appointments, which is a really sad fact before somebody takes notice, okay? This is where you need to stand up and sort of, advocate for yourself. And I'm sorry that that's the situation that you have to kind of fight to be heard. And I hear this in lots of different other realms of women's health, where people get dismissed. The one thing I would say is that sometimes, I know life is chaotic and I have to be diplomatic about how I say this, but sometimes people come in to a consultation with all sorts of things that are going on in the background. They're on speaker, there's kids screaming, they are in the shops. This is your time, okay? And I know you probably won't do that, but be prepared prior to your appointment. So things like keeping a symptom diary, being very specific about your concerns, have 2 or 3 concerns written down. Have somebody with you at an appointment if you feel that you're nervous or may forget. I think the other thing is be explicit with what you're worried about. Okay, as a GP, I was trained in communication skills. You might not know that, but you might not even be showing my communication skills. I'm hoping I'm talking clearly. But and what we're trained in is to identify somebody's ideas, concerns, and expectations. Okay, it's called ICE. So we should be asking you, what is your idea? What do you think is going on? What are your concerns and what are you expecting? Now, if you know that that's kind of what you should be getting at your consultation, frame your consultation in that way. I'm worried about this is what I think is going on, and this is what I'm hoping you're going to do for me. And that's great, you've done the GP's job, okay? Don't be worried about speaking up in that way. So you've taught me beat, I'm teaching you ice, okay? All right, so that's hopefully how to get the most out of your consultation. What else do I need to say on this slide? We've already covered off the fact that you know about the pitfalls of diagnostics. And if you're worried about how long you're waiting, there are other ways in which you can get into your GP, okay? Book in to see your nurse. Go to your practice manager and say, I'm not happy with the access here, I need more support. And I'll talk to you a little bit more broadly about the other people that are in that building that might be able to support you, like social prescribers, psychological therapy that could be provided through social prescribing, or sort of financial administrative support that can be supplied by those guys as well. So there are other ways of getting in, okay, and use them because they're probably easier to get an appointment with, and they always knock our door. Okay, that's the other thing is, you know, I will have people come and nurses will come and say, I know you're not seeing this patient, they're not on your list, but actually we're really worried. That happened last week. We had somebody come up to the front desk, really upset, and they're like, could you see them? Or can I navigate how to manage their care? And if I can't see them there and then, we'll sort something out, okay? So there are ways around these things. Okay. I do a lot of gynaecology and women's health. I do that more than I do general practice. I feel like a bit of a fraudulent GP. I barely do any general practice, but I am doing GP this afternoon. And I find it really helpful to write stuff down. These guys had some videos that they wanted me to do, right? And I had 7 questions. They were like, oh, don't worry, just wing it and it'll be ad hoc. I came with a script, okay? And that's because when you're trying to get a clear message across, you need to be pre-prepared. I need to know what I'm saying. And it's exactly the same with your consultations. To try and figure it out there and then feel like you're pressurised and you've got 10 minutes, you can rush out the door, it's never going to work, is it? Okay, so if I know there's a lot going on, but if you have an opportunity to sit down, think and reflect, and remember that ICE, ideas, concerns and expectations, just go in with a script and kind of go, this is it, this is what I've got. Or even on your online form. So I quite like the diaries, and when women come with their period problems, for example, when I see them, it is quite helpful to know, you know, you're tracking it to some extent. I don't need to see years worth of data, okay, just need to get a gist of what's going on, but it is helpful. Okay, this is a big one, right? So, you know, I've talked about the battles of access. I'm not going to shy away from the fact of what I'm about to say, which is a very sad thing. People do get dismissed, people don't get heard by their primary care team, and we talk a lot in women's health about misogyny and the fact that women are told to put up and shut up and etc. And on top of that, women are carers for their family, their elderly folk, holding down jobs, and so there's an element where they just also overcompensate and manage, and therefore sometimes want things to go away and find it hard to navigate all of these symptoms on top of life. But that is what we face, okay? And I can't promise, nor can the next clinician, that that's going to change rapidly, okay? And therefore I will always ask people to advocate for themselves, to fight for themselves. And I say that with a lot of sadness because you shouldn't have to, but that's the reality. There's no point me sitting here pretending that there is anything other than that we're going to have to do, okay? So I take a deep breath while I say this, but when you're advocating for yourself, I've already said, please be specific and actually direct. Some of the videos that I've just done, I'd like to share some of those details with you, which is have a list of who's involved in your care, okay? Don't expect that there's any shared records when you're going from primary care to secondary care. They aren't necessarily shared. In actual fact, often they're not. And it's really helpful if you have your outpatient letters, for example, or at least you have your named consultant and contact details for yourself as well as for your clinician. So, for example, as a GP, I would expect to continue to care for you after your diagnosis of ovarian cancer. It's not just hospitals that are dealing with your care. So we are your gatekeeper and your advocate as well. Now, if I don't know who to contact, you can imagine there's a bit of faffing around that goes on with that, and you'd be surprised at the number of people that come and kind of go, no idea who's looking after me, okay? So there's an automatic delay while we faff around going from medical secretary to medical secretary, figuring out which hospital and who's looking after you. Have a list, have that in your diary, know who your CNS is, know who's involved with your care, okay? So that you can facilitate that communication. I think the other thing is that I think it's such an overwhelming time that it's completely appropriate for you to have people with you, okay? Gone are the days since COVID where families aren't allowed in, all right? I actually drag people from the waiting room kind of going, why have you left him out in the waiting room? He's your second pair of ears, or she, bring him in, okay? One thing I have learned is not to presume that who they are. I've made a mistake. Nice to meet your husband. Oh no, sorry, that's your brother. Okay, that's a disaster. So, but maybe introduce who they are and that helps. But, do bring somebody with you, and you are absolutely allowed, and you should have somebody in if you need to. Okay, they are your advocate. We've already talked about this, but I'll keep repeating it. Write down your ideas, concerns, and expectations. Here's the other thing. What's going to happen next? Tell me what we're going to do. So, so you're going to send me off for some diagnostics, or you're going to liaise with my secondary care team, and that's fine. When am I expecting to hear from you? What should I do if I don't hear? And what's going to happen next? Which is tricky, okay? But I think you do need to hold people to account. Sometimes I have to be a bit vague because it depends on the advice and guidance that I get back. But I think it's perfectly reasonable for you to ask those questions that you're kind of going, what time frame am I expecting to wait and find out? This is the other thing. If you're not happy, many GPs have another GP that you can see. Come back in and go, we see this all the time, unfortunately. Not just GPs, I work in a community gynae clinic, and sometimes our consultants don't have fantastic bedside manner, just the same as some of the GPs. And people will come back and go, didn't understand what they were saying, they didn't hear me, they didn't meet my needs, I'm not happy, I would like to just go again, and we'll repeat the consultation. Now, you don't need to be worried about raising that concern, that's just a fact. That doctor then needs to go away and reflect about the fact that they haven't served that patient, and therefore they may need to think about the way in which they're communicating and what's going on there, and we've had to do that. That's our responsibility as professionals to make sure that we are serving the needs of our patients. That's our job. So if you're not happy with your appointment, go and get a second opinion. Go back in, be explicit. It wasn't a great consultation. I want to go again. If you're not happy with your GP, go to your practice manager and go, I'm considering leaving. Okay, the quality of care isn't great. I want to register elsewhere. I'm not happy. Give them an opportunity to try and rectify it. If they're not answering, then you've got PALS, and you've got CQC, you've got the Ombudsman, you've got many routes to be able to escalate that. I used to be the medical director for our organisation, and I would have to head off complaints from all of those organisations, sometimes rightly so, okay? Sometimes there's complete breakdown in communication, and therefore there's been an incurred delay to care, okay, and where we have to be accountable, we have to learn. So there are routes for you to get a second opinion. Has anyone had to use PALS or anyone else like that to escalate their concerns?
You missed it.
Right. I'm going to share it's not ovarian cancer, but I hope, I don't know whether this will give you some comfort or not actually, but my dad had lung cancer. He was diagnosed at stage 4. At the age of 69, he was still a practicing GP at the time, he hadn't retired. And it had got missed on his CT. He'd got epigastric pain, tummy pain, and they found fluid on his lungs and they ignored it. So because it wasn't what they were dealing with, they weren't looking for lung, they were looking for stomach. And then he came to the QE with a whole lung of fluid that then got drained, and he was stage 4. But when he was treated, it was during pandemic, and there was no communication. We couldn't come in with him. We'd drop him off at resus with sepsis, with an infection, and then never hear from him. And he was trying to communicate to us in that state on a mobile phone, but none of the medical team would call us. Me and my brother were both doctors, and we put in a complaint to PALS, and we just went, this is not appropriate, we can't speak to this man, poor man who's really struggling, we need to have a bit of an update. I mean, just once an admission would be great. We did find PALS helpful actually, because the next day the consultant rang, and it was helpful. But do know that if it's not PALS, then you've got CQC and Ombudsman. Okay, there are other routes that you can go down. I'll come on to that in a second, sorry, your question. And we get scared when people like CQC and Ombudsman start to kind of like, get involved, because actually that's upping the ante. I would just ask that you try going directly to your teams first. Sometimes we've got people going straight up here, and we're like, try and communicate with us if you can. But there are other routes that you can go down, sorry. Ovacome, so they are here to support you. And more and more in my career, I have found using charities, voluntary sectors, peers, leaders in communities more and more helpful, because actually they hold the trust of the communities, they understand, they hear your voices, they speak your language much better than healthcare professionals. And so we work a lot with charities in our gynaecology service to spread messages. Okay, very quick bit. I've got quite a lot of passion around health inequalities. I'm Asian in background. As I say, I've worked in very deprived areas. And the one thing that I would say is, if you are supporting people through who don't speak English as their first language, or maybe are not educated in terms of literacy, etc., or have disabilities, it is super hard. You've already got a difficult diagnosis, and then it's super hard for you to navigate the NHS. You can't really, you're limited in how much you can advocate for yourself. Here this goes, you've got an entitlement to have an interpreter. Sometimes it's probably best to get a formal interpreter, have somebody there with you. It's important that you're signposted to various different languages and resources. That there's no point having stuff in English if you're not able to read it, okay? So ask for where's reputable, here's the emphasis. A lot of people are going on YouTube and Google and TikTok, misinformation, there's a hell of a lot out there. So, ask your clinician, who do you rate, who actually works alongside charities to make sure that this is credible information that's evidence-based and reliable. You probably already know, and I said this at the beginning, that unfortunately those from from an ethnic minority background are more likely to have stage 4 cancer and poorer prognosis. So if you are supporting people through that, there is that additional sort of almost responsibility that we have to reach them and support them, okay? And it's something that we continue, me personally and Ovacome to try and drive forward that message. I think because I'm running out of time, does that include 5 minutes for questions, Liz? I haven't left time for questions, have I? No, okay. Sorry. So I'll wind up there. Okay, so, quick recap. You know about BEAT. Don't rely on CA125. Don't rely on ultrasound scans. Keep a symptom diary. You guys have said it's more helpful during treatment. That's fine. Please advocate for yourself. Know your rights. How to escalate. Ask for second opinions. And no one should be on their own. Okay, this is a scary time. There's lots of support out there. I know the NHS is broken, but there's a hell of a lot of resource that you can tap into.